So what I will do is I'll just give a brief of what we do, what are the pearls of using insulin in end organ failure and post-transplant patients. I'm going to do this overview, insulin use in CKD, insulin use in hepatic impairment, and insulin use in transplant patients. Now, we all know the most common cause of chronic kidney disease is diabetes and hypertension. I just picked up usage of insulin, this slide, usage of insulin in patients with chronic disease, chronic kidney disease from the Indian Kidney Registry. And then we have more than around 60% of these patients who are only on insulin, though I like most of them to be on insulin. We have a minority of patients still on OHAs and some on diet and XOS alone. This is from the registry. So what is different in chronic kidney disease? We all know kidney metabolizes 20% of circulating insulin, contributes 20% of gluconeogenesis. Most OHAs are excreted by the kidney. Exogenous insulin, the T half of insulin is prolonged if the eGFR is less than 60. Food intake is often erratic in advanced kidney disease. So all these to be kept in mind when you want to choose a type of insulin you want to use in patients with kidney disease. So the pharmacology I just want to touch upon this. In non-diabetic individual, 40 to 50% of insulin secreted is extracted during its first passage through the liver. Of the total 25% renal insulin clearance, approximately 60% occurs by glomerular filtration and 40% extraction from peritubular vessels. This is very important for us so that it gives us an idea as to see what type of insulin you can use and predict its half-life so that not to cause too much hypoglycemia and also exaggerations. Now, there's no specific recommendations. What I did was pulled out certain studies on the use of prandial insulins in CKD. We have all the prandial insulins listed here, regular insulin, aspart, lispro, and glulisine, all the short-acting insulin, and these are the studies which are available to us. What it shows is, if you look at a PK/PD study in CKD, it shows that they're studied in all stages of kidney disease, with GFR less than 50 and end-stage renal disease. And what do we have? Please look at the slide. We have three different insulins here, lispro, aspart, and regular insulin. If the eGFR is greater than 90, you need not change the dose of insulin. If the eGFR is less than 60, you need to decrease the dose of insulin, especially of regular insulin and lispro, by around 25 to 30%. But aspart, the PK/PD didn't change, but in practice, you do say that you also need to decrease the dose a little bit. What about longer-acting insulins in chronic kidney disease? So we have a couple of studies on glargine, detimer, and degludec, and the PK/PD data of all these three. They've studied in chronic kidney disease and end-stage renal disease. So what we have is, if you look at the pharmacokinetic and profile of insulin degludec in renal failure, in whatever the GFR, it doesn't really change much. That means there's no change in dosage required if you use long-acting insulin like degludec. The PK study in renal failure, there is no significant difference between normal and variable degree of renal impairment when we use degludec. So, in summarizing basal insulin use in renal disease, if the GFR if more than 90, there's no need to change the dosage of glargine, detimer, or degludec. Degludec, whatever the GFR is, you need not change the dose required, the basal dosage required. But for glargine and detimer, if the GFR is less than 60, you need to decrease the dose from 25 to 30%. What about common biphase mixed insulin, which majority of our patients use, and that's what we say, many of them are on premixed insulin? There's not much data available, but you need to know many of these premixes have either aspart, sometimes if they're an analog premix, They have aspart or lispro or aspart degludec. But if you're using a combination of aspart degludec, you can without much change in the dosage. But remember, when you use premix, majority of them which are available apart from degludec aspart combination are with NPH, and NPH peaks at some point of time after 6 to 8 hours, and the prolonged half-life in patients with CKD, and the chances of hypoglycemia are more. So this is from an Indian study, a review article written by Rajesh, Dr. Sarita Bajaj and all of them, and which recommends that if the eGFR is greater than 60, there's no need to reduce dosages, but between 16 and 15, there are 25% decrease, and if the GFR is less than 15, you have to decrease 50% of the dosage of insulin what the patient was getting previously, or even if you want to start, the dosages are half and quarter depending on the GFR of that particular patient. So in summary, in chronic kidney disease, more than 50% of patients with diabetes having CKD are treated with insulin. Initiate insulin at small doses with strict monitoring patients with diabetes having CKD. Newer insulin analogs may be preferred. Dose needs to be titrated as per requirement to reduce the risk of hypoglycemia. In hepatic impairment, I won't go into details. I'll skip a few slides so we can have more discussion. Insulin is the first line of treatment. Use short-acting insulin because both hypo and hyperglycemia occur in hepatic impairment. And because of decreased appetite and excessive abdominal symptoms, it is preferable to give the short-acting insulin if he's taken the meal, after the meal too, which is a practical point to keep in mind. And this is a study showing degludec, and there's no need to change the dosage. Evidence of other insulin analogs, a couple of studies. But what is the prescribing information which you have on all the insulin labels which are available for prescription today? It is suggested that frequent glucose monitoring and dose adjustments are required, and to minimize the risk of hypoglycemia or hyperglycemia in patients with hepatic impairment. Now, expert group recommendation, what is the recommendation? Dose has to be titrated to requirement to reduce risk of hypoglycemia. Newer analogs and shorter acting analogs are better in patients with with hepatic impairment. Now, this is a new terminology the last 10, 15 years. We have a lot of patients with transplant. One thing you should remember, a transplant patient, they may have had diabetes previously, or the majority of the patients with transplant will develop diabetes. If you look at all the solid organ transplant, and this is the data available, 70% of patients who undergo a kidney transplant who are not diabetic will become a diabetic. Please remember that all patients who undergo transplants are on high doses of corticosteroid, immunosuppressive agents, and majority of these immunosuppressive agents also cause, or say if you're using drugs like tacrolimus and others, they also suppress insulin production, and the chance of people developing diabetes apart from steroid, there's also already steroid use, so majority will develop diabetes. So it's very important that you frequently monitor for new onset diabetes or post-transplant diabetes mellitus in patients who undergo transplant. Now, what are the different clinical scenarios in a transplant patient? One, initially, immediately after transplant, patient is on high-dose immunosuppressions and steroids, so IV insulin, frequent monitoring in the ICU, so be very careful, may require large doses of insulin and the infusion form, and depending on early good blood glucose monitoring, you need to change it. Similarly, with the first week of transplant, their doses of the kidney functions or whatever the function of that organism, if it's a kidney transplant, typically that's what we see maximum, they start eating when they're transitioning to oral, start eating, and then they have the dose of immunosuppression are reduced and the kidney starts functioning, you need to transit to subcutaneous insulin. And sometime during acute rejection, there'll be boluses of steroids which are used. So if boluses of steroids are used, it was advisable the patient is on NPH because that has shown the best results along with short-acting insulin. But if you can't control with that, you also could consider IV insulin during that time. In TPN and enteral feeding, it is increased insulin requirements, so you adjust the dose accordingly. So goals of therapy in transplant patient is similar to what regular treatment goals for treatment with hypertension. So I would summarize to say that post-transplant diabetes is challenging to treat. Incidence depends on type of transplant patient has undergone. The treatment depends on various clinical scenarios and the time from transplantation. Treatment targets are similar to other groups of diabetes mellitus, however, should be tailored individually. Thank you. So we'll take some questions.
Thank you, Sanjay.